Hi, I'm Jeffrey Lowe, and on behalf of the Healthcare Improvement Group at the Yale School of Medicine, the Yale Healthcare and Life Science Club at the School of Management, and the American Medical Student Association student group here at the Yale School of Medicine, I'd like to welcome you to our debate. We'd like to also take this opportunity to thank the Benjamin Rush Society and the Arthur N. Root Foundation for their generous support of this event. Tonight we're here to talk about the cost of American healthcare. We spend more than any other country in the world, and this is an issue not only of the solvency of our government, but of the health of our society. Tonight, we're going to be debating the proposition, markets with limited government intervention are the best way to control spending growth in healthcare, and you will vote on the winner. Please vote now. We have a cell phone number, and if you text in the number 1 if you support the proposition, the number 2 if you do not support the proposition, and the number 3 if you're undecided. And it will only take the numbers 1, 2, or 3. So please, only text in those numbers. While you're voting, I'm going to start to introduce our debaters tonight. In support of our proposition, we have Dr. Avik Roy. He is a senior fellow at the Manhattan Institute. He is an author of The Apothecary, the Forbes blog on healthcare policy and entitlement reform. In 2012, he served as an advisor to Mitt Romney's campaign on healthcare policy. He's the founder of Roy Healthcare Research, an investment research firm in New York. Previously, he served as an analyst and portfolio manager at JP Morgan, Bain Capital, and other firms. He attended the Massachusetts Institute of Technology, where he studied molecular biology, and he received his MD. He is an alumnus of our very own Yale School of Medicine. Josh Archambault. Josh Archambault is Pioneer Institute's Director of Healthcare Policy and Program Manager for Middle Cities Initiative. He's the editor and co-author of The Great Experiment, The States, the Feds, and Your Healthcare. Prior to joining Pioneer, Josh was selected as a Health Policy Fellow for the Heritage Foundation. In the past, he has served as a senior legislative aide in the Massachusetts Governor's Office of Intergovernmental Affairs and as legislative director in the state Senate for Scott Brown. He holds a master's in public policy from Harvard's Kennedy School of Government and a BA in political studies and economics from Gordon College. Opposing the proposition tonight, first is Dr. Elizabeth Rosenthal. She is recently retired for her moronic practice of dermatology after 35 years. She continues on the clinical faculty of the Albert Einstein College of Medicine, and for the past 5 years, she's been active on the board of the New York Metro chapter of Physicians for a National Health Program. Speaking and writing on healthcare reform for the past several years, she is a passionate advocate and of expanded and improved Medicare for all. She's a graduate of Smith College and received her MD degree at NYU Medical School. She lives in Larchmont with her husband, who is also a physician and here in attendance tonight, and they're the parents of 3 grown sons. And finally, Dr. Bill Sage is a visiting professor of law at the Yale School of Law. He is the Vice Provost for Health Affairs and the James R. Doherty Chair for Faculty Excellence at the University of Texas at Austin. Before joining the Texas faculty, he was Professor of Law at Columbia. Professor Sage is a member of the Institute of Medicine of the National Academies. He is elected fellow of the Hastings Center on Bioethics, and he serves on the editorial board of Health Affairs. He holds an undergraduate degree from Harvard College and medical and law degrees from Stanford University. He has practice experience in both medicine and law, and in 1993 directed 4 working groups for the Clinton administration's task force on healthcare reform. And finally tonight, our moderator will be Dr. Jack Hughes. He is a professor of medicine at the Yale School of Medicine and directs the first-year course on professional responsibility, which covers the topics of medical ethics and the organization of our healthcare system. He has helped to develop patient classification systems for use in computerized patient care data, as well as methods for detecting potentially preventable hospital complications and readmissions. His academic interests include the evaluation and comparisons and risk adjustment mechanisms, healthcare finance, and cost containment strategies. Let's welcome our guests tonight.
welcome. Notice this phone number to which you can direct questions that you wish to direct to the debaters. Only an administrator can install software. Thanks. I swear, I had no intention. For those of you who were distressed by the absence of liquid refreshments, understand that this is an exercise in trying to deal with restraints. That's what we are about here tonight. Now, to explain the format of the debate, our panelists will proceed in order. Our first panelist, Dr. Avik Roy, will speak for 5 minutes. Then Dr. Rosenthal will speak for 8 minutes. Mr. Archambault, will then talk for 8 minutes. Dr. Sage will talk for 8 minutes, and then Avik Roy has 3 minutes to respond. At that point, we actually can begin taking questions at any point. Those questions will be brought forward after the panelists have finished their presentations. I will be presented with questions, and I will be helping select them. I will have a few questions of my own. The total question time will be about 30 minutes. Well, no, it will be exactly 30 minutes because, after all, I am the moderator. At that point, we will ask you to vote again. But we will continue taking questions until the second round of voting is tallied. All right, and then Jeffrey will announce our winner. All right, then without further ado, let me introduce once again Dr. Avik Roy, who has a few slides to present.
All right, let's see if I can get this to work.
Yes.
Thanks, Dr. Hughes, and thanks for having me here. I haven't set foot in this auditorium since I was a 4th year, and I think the carpet is a different color, but otherwise it looks basically the same. I think this is the simplest point I want to make, that it's easy to waste other people's money. If you want to understand why the U.S. healthcare system is inefficient, it's because we're spending and wasting other people's money. The U.S., we talk about this whole idea of the U.S. being a free market system and Europe having single-payer or socialized systems. That's actually not true. So the U.S., we don't have a free market system. About half the population is in roughly single-payer health care. They're in Medicare or Medicaid, which are government-run programs. Then you have another big chunk of people who are in the employer-sponsored system, which is that first bullet point there. People who are getting employer-sponsored insurance, yes, it's private insurance, but you're not buying that insurance for yourself the way you might for car insurance or homeowners insurance. You're getting that insurance from someone else, from your employer. The fact is that 90% of the people in America who have health insurance get it from someone else. It's chosen for them by someone else. So when economists talk about the inefficiencies of third-party insurance, which is to say, if somebody else is covering the cost and you're paying a premium, you kind of have an incentive to go to town, like at an open bar or buffet dinner. That's especially true if you have not only third-party consumption of health care, but third-party consumption of insurance, So we really don't have a third-party payer system in America. We have a ninth-party system in America. So if you're that removed from the cost and value of your own care, isn't any surprise that health care in America is so expensive. The other thing to mention is that Europe is not all the same. There are some countries in Europe that really do offer socialized medicine, as we understand it, technically speaking, and other countries that don't. There are some countries actually in the developed world that have fairly market-oriented systems. So the UK is the classic example of a socialized system where the government owns the hospitals, the government employs the doctors, the government pays for the insurance. Then there's France, a country that, if you add it all up, is actually about the same as America in terms of its components of free markets versus the government. So in France, they have a basic plan that everyone has to get, And then on top of that, the supplemental insurance that you might buy to cover other things is pretty much unregulated, much less regulated than the US. There are some countries that are more market-oriented than the United States. So Switzerland has a system in which there is no public option. There is no government-run insurer. The system is actually a lot like what the Affordable Care Act exchanges do for a certain bracket of people in terms of income. And it's a lot like what Paul Ryan's plan for Medicare reform would do. And of course, it's a lot like what Mitt Romney tried to do in Massachusetts. And in fact, Mitt Romney got his original idea for this from the Heritage Foundation and from Switzerland. Singapore has a very interesting model. In Singapore, you have universal health savings accounts. So everybody has a health savings account, which they put money into over time. The way it works is there's a payroll tax, comes out of your paycheck, the way it would for us for Social Security and Medicare. That money is then put back into your health savings account, so you're required to save. And then you use that to shop for most routine health expenditures. And then they have catastrophic universal coverage if you get hit by a bus or you have a stroke or what have you. So there's catastrophic insurance for serious, truly catastrophic health problems. And there's health savings accounts which incentivize you to shop for your own care for everything else, which is a system that most market advocates support. So one thing you hear a lot about is that the US should bend the cost curve. We got to bend the cost curve. Healthcare costs in America are growing out of control, and if we could just be like those Europeans, we would bend the cost curve. Well, here is a chart, a spaghetti, basically, comparing annual growth in national health expenditures over the last 15 years in Switzerland, the UK, the US, and Canada. So the red line is Switzerland, the blue line is the UK, the green line is the US, and the black line is Canada. And what do you see? You see that actually growth in all these countries in terms of healthcare spending is roughly the same. The growth rate is the same. Right? The US is actually slightly lower than that of the UK. And Switzerland is slightly lower than the US. But really, there's not that much of a difference. One thing else you notice, when you get to 2010, look at all those numbers go down. The recession has led to a real slowdown in the entire industrialized world of healthcare spending. Here's a talking point you hear a lot these days. Well, there is no Medicare spending crisis. We don't have to worry about Medicare because Medicare spending growth has slowed down. And that is, in fact, the blue line and the light blue line. So the light blue line is total Medicare spending that's up there at the top. The dark blue line is Medicare spending per enrollee. Because the baby boomers are retiring, more and more people are on Medicare. So if you adjust for that, Medicare spending is still going down. But that black line is the OECD average, which is all the people who are in the industrialized world. So Medicare is still spending more and mirroring, really, but still spending more, growing more than healthcare all around the world. And what do we see here? If we look at public expenditure per capita.
Actually, what you see is an impertinent moderator.
Okay.
Trying to close you down.
Yeah, so let me just conclude on this, because this is my last slide. The U.S. spends more per capita government spending than almost every country in the industrialized world. What countries are at the lowest? Switzerland and Singapore, the market-oriented countries. So if you want to have real control in healthcare spending, look at the market models, not the single-payer models, because that's where you get less spending.
And you can return?
Yeah.
All right. Thank you very much. Dr. Rosenthal, I believe you have a few slides that you would like to share.
Jack, a principle of lawyering is you never make your argument with your opponent's slides still up, so would you scrap that, please?
I certainly will. Now, yours are, you know, just keep going.
And we'll get to mine.
No, maybe not.
With that?
Yeah, okay.
Yeah, that's what they told me. No, that's not how it's working. They told me I just have to press that.
Yeah, well, that's the way it should work. Here we go. This is where we want to go?
Yeah.
There we go. Okay, you didn't lose any time for that.
Hello, I think my opponents and I agree on one thing. We all agree that we're spending too much on health care. Now, I'm not a policy wonk. I'm a doctor, and I'm going to come at this the way it affects patients and affects me as a physician and my family and regular people. It's true, we're spending too much on health care. Most people in our country, unless they're very wealthy, worry about how they're going to pay their doctor bills. It's a big worry. Many people are one job loss or one serious illness away from financial ruin. It's not a pretty picture. 60% of the bankruptcies in our country are due to medical debt, all or at least in part, despite the fact that 3/4 of those people had insurance at the outset of their illness. So we have a very big problem. And this burden of healthcare spending, now I'm talking about not spending just by the government, I'm talking about everybody's spending. Spending by the government, spending by companies, employers, individuals, all of it put together. And our spending is totally a burden on individuals, families, employers, and on businesses, because businesses have to pay for the health care of their workers, and they compete with companies that don't have to do that. So it's a big problem for everybody. And I will show you, I have slides that are exactly the opposite of his slides, dueling statistics. So to me, this really says it all. This is the total health expenditures as a percent of GDP. And you can see there's a whole bunch of countries clustered around one group, the color ones, and then there's the black and white line that's an outlier, and that's us. And we are spending more, and we are spending at a greater rate. It's increasing more than the other curves. So there's trouble in River City. We really have a problem. So what are we going to do about it? And why doesn't the market work? I disagree completely. I think the market and less government intervention is absolutely the wrong way to fix this problem. Rather, we need less market, more government intervention. Why do I say that? First of all, market principles do not apply to health care. Health care is not a commodity like shoes, furniture, a car. Did you ever hear anyone say, hey, Joe, I heard they're having a special on colonoscopies. Let's go have 3. It's a real deal this week. I mean, it's ridiculous. When you have to buy medical care, you're in the ambulance bleeding and afraid you're going to die, and you get to the hospital, oh, gee, and you say, oh, this looks very tacky. I really don't think I like this place. Let's go to the next town. I hear their hospital is nicer, and I think I could get a better deal there. I'll just bleed a little bit longer. That doesn't happen, right? Because health care is not the same. So what happens? The seller is in charge. The buyer is at the mercy of the seller because they can't say no. Somebody says, you need to take this insulin for your diabetes, and you go to the store and the insulin is too expensive, and you can't say, well, I guess I won't take it, so what? Doesn't matter. I'll get it next week and I'll get it next month. It doesn't happen. So the seller of health care and health equipment and hospitals and drugs, they have the power, and the buyer is at their mercy. And in this country, they charge ridiculous prices for all these things. We pay more for drugs than any other country in the world, despite the fact that the drugs are made around the world by the same companies, and we pay much, much more. I've had patients in my office, they have to choose between buying their medicine or paying their rent. They can't afford both. What kind of situation is that? Okay, so what do we have to do about it? What we have to do about it is we have to have somebody intercede between the sellers and us, the purchasers. Now, mostly what happens here is the insurance industry does that. But we have a private for-profit health insurance industry. So they are, when they intercede for you, your interest is not their main concern. They're profit-making companies. So the more health care they deliver, the less profit they make. They compete by avoiding sick people and denying care. That's how they make money. Do you want somebody like that in charge of delivering your health care? And what value do they bring to the system? They have huge administrative costs. You have to pay profit to the shareholders. You have to pay high CEO salaries. And you have an enormous administrative burden pushing paper. In my office, when I submit a bill to Medicare, they usually pay me, and pretty promptly. When I submit a bill to an insurance company, first of all, they have different rules about what to submit and what card to take and what plan you have and blah, 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 and they change them all the time. And then you hardly ever get paid the first time around. They say, no, you'll have to resubmit a claim, and you have to do that again and again. That costs a lot of money. It costs a lot of money for the insurance company to hire all those people who say no, and it costs a lot of money for the doctors pushing all that paper. I want to spend time with my patients. I don't want to spend time pushing paper and fighting with insurance companies to get paid. It's a terrible system. And we can tell that government is the best one to interfere because they're big enough and powerful enough to negotiate on our behalf and bring down the prices. My husband works at the Veterans Administration. The prices of drugs there are a fraction of what they are elsewhere because the government negotiates with the pharmaceutical companies to get lower prices on the drugs. We can't do that in Medicare because it wasn't allowed when drug coverage came into Medicare. But Medicare has the clout to pay hospitals a lot less. I don't know if anybody saw that Brill article in Time magazine recently. Hospitals charge ridiculous prices, but Medicare accepts a lot less because they have the clout to do that. So this is what we need to do. We need more and not less government intervention. My opponent is talking about health savings accounts. Well, they're very nice for the healthy and the wealthy. But if you don't have enough money to save and you get really good and sick, it doesn't really help you. And if you have a catastrophic insurance policy with low deductibles, what happens when you get sick? First, you have to pay a whole lot out of pocket before you even go to the doctor. And if you don't have a lot of money, you can't do that. And then when you get sick, the coverage is very skimpy. So the thing we need to do is we need to have a single-payer, Medicare for all, government-regulated system, and everybody will be covered like it is in Canada. I visited Toronto, and the billing department in Toronto General, which is the same size as Mass General, is one room with 3 employees. The billing department in Mass General is a whole floor with hundreds of employees. So all that waste that my opponent was talking about isn't because people go to the doctor much more than they really need to. Loads of people in our country go to the doctor much less than they really need to. All that waste is all that paper pushing and all that administrative cost. And if we got rid of that, we could cover everybody at a much more reasonable cost, and we would join the rest of the civilized world that has already learned this lesson.
Mr. Archambault. Mr. Archambault will orate and has no PowerPoint slide.
I'm going to make you listen to me instead of look at something. Thank you, Mr. Hughes, very much. Thank you for the organizers for having me come down from Boston. And I'm sure that those of you in the balcony are wondering if an undergrad wandered onto the stage by mistake, but no, I can assure you that, that I was invited tonight. But anyway, I think our colleagues on the other side would agree that the status quo that we have now has largely been shaped by government intervention. Firstly, a seemingly arbitrary World War II era IRS ruling on the tax treatment of employer-sponsored insurance has driven most of the dysfunction that we have in the insurance marketplace. We currently have an extremely regressive system in which the unemployed, the working poor, and entrepreneurs get the short end of the stick. Second, the Medicare payment policy accounts for many of the perverse incentives in our current system. You often hear policy people say, as Medicare goes, so goes the whole system. But putting those aside for 1 minute, let's focus on 3 illustrative examples that I believe point to the ability to better control spending growth with more limited government intervention. The first one is eye surgery and breast implants. The second one is consumer-driven healthcare insurance plans. And the third we'll end by talking about Medicaid. This will take our conversation down to the micro level, which I think is really important since it often highlights and provides a window into the incentive structures that exist in healthcare, and it reveals how individuals are reacting to those incentives. So let's talk about eye surgery and breast implants. LASIK eye and plastic surgery are 2 of the best examples of how a market can evolve and simultaneously save money and provide high-quality care. The commonly known LASIK technique was conceived in the 1980s, but didn't receive FDA approval until 1999. But even with this late start in the States, it's performed millions of times a year and has one of the highest patient satisfaction rating of any surgery according to Consumer Reports. In 1999, the average cost was roughly $2,200 per eye. Now it's closer to $1,000, 55% cheaper. How many other medical procedures share this declining pricing structure? Very few. So why have the prices been able to go down? Competition, which has been made possible by transparency of prices, improvement in technology, sure, of course, but most importantly, the consumer controls more of his or her healthcare dollar and has the incentive to find the low-cost, high-quality provider. Just to be clear, there still is limited government intervention here. I can't pick up a knife and legally start to offer surgeries at my house. The surgical centers are regulated by both the state and the federal government. The tools are regulated, and of course, training is required. But the government doesn't set the price here. While LASIK surgery is not medically necessary in most cases, it does serve as an illustration for the potential to save significant amounts of money by delivering innovative, high-quality care. We've seen disruption work successfully and benefit billions of people in the form of computers, cell phones, digitized music, and low-cost airline carriers. So where's the disconnect in medicine? Why don't we have more of this consumer-driven disruption innovation in the marketplace? The answer lies mostly with who's the real consumer. As unsexy as it may sound, who picks your insurance design is pertinent to controlling spending, as Avik pointed out. When individuals are given a set amount of money and a defined contribution and given real choice, they pick insurance for themselves that tend to be a wiser choice for them. Many pick consumer-driven insurance products. Under these plans, the consumer faces some level of a deductible, which translates into a lower premium. That's how they work. And the plan is paired with a health savings account, or an HSA, or an HRA, or an FSA, or some combination of these. But let's just focus on health savings account for a moment. It's like a debit card. They're funded with premium savings by the employer and/or from employee contributions. And these consumer tools help cover out-of-pocket expenses and can be used for things like eye and dental care and long-term care. It's important to note that these are triple tax advantage money and are owned by the employee for life, regardless of whether they stay at their employer or not. But most importantly, they engage a consumer. The review of the literature strongly supports the benefit of these products to control spending growth. These plans carry a 10 to 28% lower premium contribution for the employee and a similar reduction for the employer. Participants are more likely to join a disease management program, report fewer medical emergencies, and increase their participation in preventative services if structured properly. But there's more for those with chronic conditions. They receive care at the same or higher levels than those on a traditional plan. Enrollees are also more likely to engage with online tools, 24-hour nurse hotlines, and to use mail-order prescription drug services. Of course, these actions matter not only because they control spending, but also because in a recent national estimate by RAND and published in Health Affairs, it was projected that by increasing HSA utilization to 50%, we would instantly save $57 billion as a nation. As future doctors, you know the long-term value of healthy patients. Because we know 70% of current healthcare costs are related to treating diseases caused by lifestyle choices, we need to capture as much of this health dividend, as I call it, as we can, and these plans can help in that effort. Proof of the reduction in growth can be seen anecdotally in the private marketplace as well as in government programs such as the state of Indiana, where now 90% of their state employees have health insurance with HSAs. And they've saved, on average, 11% every year since they instituted it in 2006. But I'd like to close with the possibility for a public program, Medicaid, for low-income and disabled folks. I want to share a story that I think illustrates the power of moving in this direction of less government intervention, even in this program, which has some of the most medically needy citizens in our country. Morris Brutus is a 20-year-old African-American man in Florida. Morris was in a terrible motorcycle accident in 2011, and his family was told he had less than a 1% chance of survival. Upon waking from his coma, he found himself a triple amputee and deeply depressed. I met Morris a few months ago at a conference, and we talked about his experience in a pilot program in Florida. The program allows beneficiaries to pick from up to 11 private insurance plans with the help of a choice coach to select a plan that best fits them and critically rewards them with an HSA-like account. Morris picked a company with a care coordinator that specializes in working with disabled patients. The plan covered amputee support groups and helped to get him moving quickly into comprehensive occupational therapy. Morris felt he was doing so well largely because of the tailored nature of the program and the assistance that he received. Morris is now finishing college, lives independently, and is training for the 2016 Paralympics. Both Morris and the director of the Florida Medicaid program were convinced that under the regular or status quo Medicaid program, Morris's story would be a much different one. His care would have been disjointed. It would be unlikely that all the insurance companies would have the insight on how to work with disabled patients. Unless you think Morris is a unique case, Florida's seen the introduction of plans tailored to HIV-positive patients, pregnant women, and other iterations for the first time ever in this market. In regards to controlling spending, the 5-county pilot saved $118 million last year, and if established statewide, this government-light model could save roughly $1 billion a year. The difference here is that in the old Medicaid program, the beneficiaries is not in control. The dollars won't follow them elsewhere if they get unsatisfactory care or coverage. Until patients in both public and private plans are more engaged at becoming value seekers in a bottom-up organic process, we will repeat the mistakes of the past. Now government dictates what the marketplace should want instead of leveraging what works to decrease the cost of insurance by lowering the cost of care. Thank you.
Yes, you may begin texting questions that you may have. Dr. William Sage is now going to join us.
Thank you. I have no slides either. Remember that what you're voting on here is that markets with limited government intervention are the best way to control spending growth in healthcare. And it's not some hypothetical country's system, it's our system, and it's not our system if we're starting it afresh, it's our system from the point we are now. And so that, I think, is what I want you to remember when you cast your initial votes. Now, I look for points of agreement. I'm actually very interested in points of agreement around Medicaid, where I think there are many. But I want to talk a little bit in criticism of some of the points that have been raised, and then kind of give you my own thoughts about the role of government intervention in our healthcare markets at this juncture. I'm a little taken aback that a free market conservative would hold Singapore up as an example. Singapore is a dictatorship, for those of you who don't know that. And the money that contributes to actually a very good and often lavish Singapore healthcare system is not voluntary savings, it's coerced savings. When I did a hospital transaction in Singapore several years ago, the Singaporean driver who took us from place to place, when asked, said, "Singapore is a fine country." I said, "What do you mean by that?" He says, "Whatever you do, they fine you." I'd also like you to think a little about health savings accounts. Now, when I teach this material, I always give credit where credit is due to health savings accounts. They had a theory of healthcare spending from spending other people's money, consumers' moral hazard, and an intervention, the health savings account, intended to address that moral hazard. But for those of you who know surgeons, you'll know there's a saying that says, you know, if all you have is a hammer, everything looks like a nail. And if all you have is a health savings account, everything looks like consumer moral hazard, where in fact much of the problems that are inflationary in the US healthcare system are not decisions individuals make. They're decisions healthcare providers make, they're decisions government has made, and they're structural consequences of various sorts of policies that we've adopted over decades to centuries, which actually allows me to start talking about why markets with limited government intervention is an unrealistic fix at the present juncture. And I want to talk about three things very briefly. One is I want to assert that governments created the markets we currently have. Second, I want to assert that government has to lead these markets in new directions. And third, if I have time and I'm not cut off, I'll urge the conservatives here to be a little more true to their core principles than I often hear. So in terms of government creating the markets we have, understand I come from Texas, where government is this evil thing that lurks off in the corner, usually in Washington, D.C. The government that created the problems in healthcare is not a them government over there, it's an us government. It's the government we asked for, it's the interventions we requested over a long period of time. It's also been a government that largely, because we were willing to have it do so, empowered the medical profession to spend our money. So over the long haul, you know, this is a function of the professional dominance of the system and not some notion of you know, government policy or government subsidy. And a good example of this is the unique to North America forced separation of physicians from hospitals structurally, which no country in Western Europe shares, and I would argue it's been one of the most inflationary factors in our healthcare system. Now I want to say that government really has to lead us out of this mess. And it's a mess of our own creation, largely through public processes. Now, this is an unusual argument if you believe in market competition, which actually I do, because typically you assert that competitive markets will define their own objectives and figure out how best to achieve them. But I don't think that's what we have in healthcare. We actually need to specify the competitive goals for healthcare markets and define our reforms accordingly. And I have actually fairly simple goals. I want healthcare to be quicker and cheaper. In general, nobody talks about healthcare being quicker or cheaper, and if they do, they say it with embarrassment. I'm not. I say it quite proudly. Healthcare needs to be quicker and cheaper, and people say, well, what about quality? What about better? And I say, well, if you really push me on this, I'll add one thing: quicker, cheaper, and more reliable. But I won't go beyond that. And I think government is going to lead us in the path, has to lead us for fiscal reasons in the path of having quicker, cheaper healthcare. Here I think there's two things you need to think about in terms of the system. There's what I call downstream health, and that's the healthcare system we all live. It has patients, it takes care of patients. It's a total inefficient mess, and it needs to be quicker and cheaper and more economically productive. But then there's this whole area of upstream health. In upstream health, there are no patients, they're just people. In upstream health, people are out living their lives. We don't say, oh, well, you got sick, we're going to remove you from your life, we'll deal with your illness, we'll restore you to your life. No, we're actually going to provide basic healthcare services to you and all sorts of health improvement activities in the course of living your life. And that is a very different competitive proposition. So I think, you know, downstream health, it's going to require government to lead the way so that what we think of as healthcare is quicker, cheaper, and more reliable, often through different payment policies. Upstream health, we have to pay attention because we have to create actually a very broad and vigorous competitive space for upstream health to occur. We also have to stop worrying so much about insurance. The typical market roles of insurance are not roles that insurance companies tend to play today, nor are they roles that we're comfortable allowing insurance companies to play today. And frankly, I don't know what a health insurance company is going to be over the next 10 years. Maybe it's a buyer, maybe it's a seller. It's not a risk bearer, maybe it's a claims processor. There'll be a role for them, but I don't know why we spend so much time worrying about the competitive environment of what we call health insurance companies today. Instead, what we really need to focus on, in my view, and this is really a government function through public deliberation, is we need to focus on defining products that work. We worry a lot about the prices of products that don't work in our healthcare system. We don't worry much about having products that actually work. So LASIK's a good example. LASIK is a product that works. Most of our healthcare system, we pay trillions of dollars for stuff that doesn't work. So if I have a minute left, let me just urge the conservative people here to be true to two of their principles. And one comes from Friedrich Hayek and one comes from Milton Friedman. The one from Hayek really says you have to not just care about whose money is being spent, you have to care about what price is being paid. Because price, to Hayek, is actually a wonder of a free market economy, not just because it saves money, but because it conveys information. It allows things to be produced as efficiently, as effectively as possible. It allows things to be transacted well. It conveys to all the participants in a broad system actually how to get the job done at the lowest cost with the best result. Well, there is not, in my view, a single honest price in the healthcare system. And getting honest prices in the system is at least as important as who's paying the prices that are there. The other piece that I would urge the conservatives to adhere to is the Milton Friedman distrust of professional licensing and other government barriers to market entry. You tend to hear a lot of complaints about Obamacare. You tend to hear very little in terms of complaints about limited scope of practice for nurses, for community health workers, for others. We need a vigorous supply of health care, both downstream and upstream, if we're ever going to afford health care generally. Subsidies are great. There are poor people out there who very much need subsidies, but you don't subsidize a market with inelastic supply. All you get is an extra bunch of dollars paid to the suppliers. So I think there's no question but that vigorous government intervention is necessary in our current healthcare system, if primarily to achieve real market competition. Thank you.
Dr. Roy, you have 3 minutes to respond. Sure. Okay. You can find it.
I'll try. Let's see here. Well, we already know that Dr. Sage believes that he's losing the debate because he tried to change the topic. He tried to change the topic to whether or not the United States has a cost-effective healthcare system versus other countries. That is not the debate topic today. The debate topic today is whether market-oriented systems are more efficient than government-oriented systems. And the United States does not have a market-oriented system. So let's talk more about Singapore. Dr. Sage pointed out that the political system in Singapore is not free, and I completely agree. And in no way do I want to model ourselves after the Singaporean political system. But their healthcare system is freer. Coerced savings, he called it. But coerced savings are better and far freer than coerced taxation when someone else is spending the money and not you. When it's your money, you can have price signals because you're paying for things. And it's not just for healthy and wealthy people, because the Singaporean government subsidizes the HSA accounts for those who are lower income. So that's how the Singaporean system has universal coverage, higher life expectancy than the United States, higher GDP per capita than the United States, and spends a quarter of what European countries spend on healthcare as a percentage of GDP per capita, and 1/7 of what the United States does. These are the facts. These are the data. And there has been no challenge to this data. When Dr. Rosenthal went up and said, well, we've got dueling statistics. Actually, we don't. The statistics and the source of her statistics were exactly the same as mine. The only difference is she didn't have Singapore on her slide. So the question really is, what is a market-oriented system and what can it do? Again, by giving people control over their own health dollars, instead of having overinsurance, as Dr. Sage pointed out, you can actually have more efficient care. And that's what Singapore shows. And what Switzerland shows, which is not a complete HSA system, it's a premium support-based system, which is, again, a lot like the ACA exchanges, a lot like Paul Ryan's plan, which is where reform is going in this country in the next round. We will have a more efficient system than we have in the US today because people would be shopping for their own insurance. There are a number of points I'm just going to make very briefly. If you want to understand medical bankruptcies and the flaws with some of the studies that have showed all these medical bankruptcies are due to medicine, Google Megan McArdle and medical bankruptcies, and you'll see all the data there. This argument that the markets can't work comes from a near religious text by a Stanford economist named Ken Arrow, who wrote this piece that everyone cites on the left. But it's actually not true, and if you Google my name and Google Ken Arrow, you'll see why that's not true. Drug spending is too high. Well, actually, it turns out that 80% of all prescriptions in the United States are for generic drugs. In the UK and Germany, it's 50%. In Italy and France, it's 15%, 11%. So the fact is, yes, for branded drugs, we spend a little bit more. We pay a little bit more than what Europe does. But over the life of a drug, actually, drug companies make far more money in Europe and Japan than they do in the United States, because there's a long tail after the patent expires in those countries where they still make money off the branded drug. Whereas in the United States, once it goes off patent, the generics come in and it's game over. So actually, we have the most efficient pharmaceutical market in the world, and we should be careful about trying to change it.
All right, sir. Thank you very much. Okay. one? Okay.
Feel free to go with your questions for the 15 minutes, but hear the initial set.
Okay, great. All right, so we already have questions, which is great, but I'm going to exercise the prerogative of the chair and ask a couple of my own. This was built in. Let me start out by asking both sides, really, and let me ask those in favor of the motion first. What is allowable under, what's an acceptable definition of limited as far as you're concerned? And then we'll ask the same question to those opposing the proposal.
Well, I think it's self-explanatory when you think about what limited government means. It means less government spending and overall a freer regulatory structure. And you add all those things up and you have a sense of what's more limited than others. So in Singapore and Switzerland, they're still highly regulated systems. So they're not libertarian utopias. And I'm not trying to suggest that any of these systems have libertarian structures where there's no government at all or it's anarchy. But you can have a system that's more market-oriented, less regulated, more price signals, less government spending, and have a pretty cost-efficient system. If you compare, again, Singapore to the mainstream single-payer systems like the UK and Canada, it's much more cost-efficient.
All right, and we can come back.
Sorry, I'm just having a bit of a Lloyd Benson moment over that comment about Kenneth Arrow. Several years ago, I designed and edited an entire book commenting on Kenneth Arrow's 1963 article, and Professor Arrow, who's still going strong in his late 90s, participated in that. So I'm kind of having that, you know, I know Kenneth Arrow is a friend of mine kind of moment here, but I won't complete the thought.
Read the article and then rebut it, and then we can talk.
I may not need to rebut the article, but I can tell you everything you might want to know about Kenneth Arrow's early piece. You know, what's limited? Well, I wish people on the right would start saying that limited government intervention is repealing antiquated scope of practice restrictions, getting barriers to entry down, and start doing that sort of thing. I'm tired if, you know, limited government intervention and to the right just means not taking richer people's money so that poorer people can have health care.
Nobody disagrees with you on that, not on this side.
I think we'll allow a response to that.
Yeah, no, and none of us disagree with you on that.
How about your colleague?
Go ahead, Josh.
I wouldn't disagree with the doctor in saying that scope of practice and other areas is really important. I think about this in a very practical manner. I work at the state level, so that's often where the rubber hits the road. The role of limited government for me on healthcare is that they're there to set the guardrails. They're there to level the playing field to make sure that folks can get in and compete. And they do have a role probably on transparency. If state governments could play that role, then I think we'd have a much more competitive system locally, and consumers would be able to operate within that, and you'd see a lot more folks practicing at the top of their license, and we'd address some of those issues with scope of practice or what you need a license for. So.
All right. Although I still have some very juicy questions, I'm going to, I want to deal some of the questions that have come from the audience. And I think this particular question goes to both sides. One of the major assumptions of the pro-government camp is that the private sector is, is that the private sector is able to innovate. So I'm assuming this is the pro-motion, pro-proposal camp. Is that the private sector is able to innovate, that is, tailor plans to patient subpopulations. Why can't government innovate? Isn't the government already trying with various pilot programs, et cetera? So we will start.
You want to take this?
You know, I can start. The government's been trying to innovate on healthcare for years. If you talk to folks that have worked in Medicare, they can rattle off the number of innovative pilots that they've tried in the past. And I don't think it's that hard for us to think outside of healthcare. How often has the government been innovative? How are they doing on the post office? How are they at the RMV? I think most of us understand, yes, they can do it well at times, but really to how large our healthcare system is, to expect after years and years of efforts that somehow they're going to find a way to lead and be innovative, I think is just unrealistic.
The real challenge is one of politics. So in political economy, you have a situation where if you try to change Medicare, a lot of entrenched interests oppose it. But in the private sector, if you experiment with a new plan, people can either choose to sign up for that plan or they can choose not to be. And through that process, there's a more organic evolution of where plans go. If you look at something like the Federal Employee Health Benefits Program, in which federal employees have a choice of many, many different plans. There's been a significant evolution since that program first began towards modernized, what we would call 21st century modernized actuarial practices, whereas Medicare is still going in basically the same design it had in 1965, because it's just very difficult once you have something. When you need an act of Congress to change any little thing about a law, it's pretty hard to do in our system.
Dr. Rosenthal.
There's one area where the government is doing most of the innovation, and that's in drug research. All of the new drugs are discovered at the NIH, which has the money to fund that, and then they're licensed to drug companies to do clinical trials, but the basic science research is all done by the government. So it's not true that the government can't do any innovation.
Well, you know, I don't think we should just disparage the innovative potential of government. Government has a bad name these days. Back in the 1960s, it didn't. We were landing people on the moon. In healthcare, innovation tends to follow financial incentives, and decisions about government coverage of innovative treatments tend to be as financially important to the companies that innovate as the patentability of those treatments. But frankly, a lot of the innovation we've had in government has been sort of this back and forth between the private sector and government, making marginal changes to what was already a complex and by design a highly inflationary system. And a highly inflationary system not because government came up with the idea, but because the public wanted it and the medical profession was put in charge of it. Now you just have to realize that the innovation that we have tends to be extremely vigorous in certain domains, like a new drug or medical device, and extremely flabby, puny in other domains, like taking the delivery of healthcare services and making it quicker and cheaper. And I think both government and the private sector are going to have a reciprocal role in opening up innovation in that domain.
Now let me ask both sides, and we'll start with the opponents of the proposal. Because both sides have pointed out the difference in spending levels between the United States and other developed nations. Can we allow you, or can we ask you to unpack the reasons for those differences? And I'd like to hear briefly from both sides. Dr. Sage.
Well, one point that the conservatives here made that I completely agree with is that the U.S. spends as much public money as any other country, to which we then add an equivalent amount of private money. And although I wouldn't put quite as much sort of causative weight on the non-taxability of employer-provided health insurance, that's certainly been something that's perpetuated a large subsidized insurance industry in the U.S. Other than that, I actually think it's complicated to tease out the different factors, and just listing aging, technology, consumer demand, defensive medicine never, in my view, gets us very far. But what I think really is important to recognize is that the cost inflation in healthcare is very much more likely to come from things intrinsic to healthcare than the outside. It's not likely to come from the greedy insurance industry or the greedy pharmaceutical industry or the bloated government or the tort lawyers. Politics really is not my point here. It comes from the core problems with our healthcare delivery system. And if you want to see, I think, the most promising political development of the last 15 years, it's that politicians are now willing to acknowledge, from all political perspectives, that our healthcare delivery system is deeply flawed and overly expensive. You used to hear routinely American healthcare is the best in the world. I did hear Governor Romney say that once in a debate, but that was pretty much the only time I heard it in the entire presidential campaign, and very few people say it because we all realize it's not true. Yeah,
I think that one thing, when I speak to conservative audiences, the thing I often have to do is explain to them that the American system is not the best system in the world, because there is still this popular perception that it is. Because if you have insurance and the value or cost of your insurance is not transparent to you because you get it from someone else, and you're satisfied with your basic coverage because when you get sick, you get treated, you think it's fine. If you look at polls, 88% of people with coverage, whether it's government or private, are happy with their insurance in America. So that's why there's this perception that the system is great. It's not until you look at the numbers that you realize that it isn't, of course, also if you're uninsured. And the point I try to make to them, and also here tonight, is that you can have a market-oriented system of universal coverage that spends a lot less money than we do. If you look at the charts that I put up 2 different charts, right? The green chart had total total health expenditures nationally, public and private, as a percentage of GDP. The blue chart had government spending per capita. And both of those charts, if you look at the green chart first, what it showed is there were 3 clusters. There was the US, which is way out there as an outlier, right? 17% of GDP spending on healthcare. Then there's basically all the Western European countries, which are in this basically 10 to 11% range. And then there's Singapore at 2.5%. So what does that tell you? It tells you that the hybrid disjointed system that we have is a complete mess, because that's what leads to a lot of this cost inflation. The European systems, whether they're single payer or they're market oriented, all basically perform the same in terms of spending, mainly because they're unified systems and there's a hybrid mix of government regulations, subsidies, et cetera. The Singaporean system is universal and has health savings accounts where you have real price signals, and that makes a huge difference. Those are 3 clusters. The big difference between Switzerland and the rest of the Western European countries is on that blue chart. Because on that blue chart what you see is that public spending in Switzerland is far lower. And that matters because as we move into an era of constant fiscal crises, the Switzerland system is much more protected against budget deficits and fiscal problems than the other Western European systems.
Okay, well, no, I don't claim to be an expert in comparative health care, but Switzerland, to my knowledge, is, before the Affordable Care Act, the last Western country to universalize their system. And the fact that they're the last to universalize puts them in a somewhat different position. I'm also just a little skeptical of the notion that the model for the U.S., an outlier in one direction, should be Singapore, a clear outlier in the other. Why don't we go somewhere into the middle?
Well, I'm not saying that we should go to the Singaporean model. I personally advocate Switzerland as a model for U.S.-based reform, as I mentioned in my remarks. Having said that, again, the Swiss system is new, but it's not that new. It's been around for about 15, 17 years, and so the chart I showed about growth in national health expenditures over that period of time looks pretty favorable to Switzerland versus the other European countries.
I think we're not going to be able to resolve this particular branch of the debate. And so then let me direct a question from the audience for Dr. Sage and Rosenthal. Do you believe the Affordable Care Act takes adequate steps to control costs? And if not, what do you believe are the next steps?
No, I don't think it takes, it doesn't control costs at all. Nothing in there doesn't say anything about what people can charge. It doesn't control costs at all. I think the next step would be to have an improved and expanded Medicare for all. I agree with Dr. Sage that our delivery system is not right, and in Canada they are trying out, doctors on salary and group practices and having other people besides physicians do some of the care. I mean, all of that is a very good idea, but it doesn't save as much money as eliminating the very, very costly middleman with all the ridiculous administrative costs. And I think the Accountable Care Act is like putting an aspirin, giving somebody with cancer aspirin. I mean, it helps a little bit. It helps a few people get health care, but it's not going to bring the cost down at all, I don't think.
I think the Affordable Care Act, the teaching point about the Affordable Care Act that's sometimes overlooked is it really is the first federal law that simultaneously tried to make significant improvements in 3 different domains. One was health insurance, one was healthcare delivery, and one was actually underlying health, which, as Kenneth Arrow wrote in 1963, is a very different thing from the medical care system. And if there were going to be a really interesting public debate over the Affordable Care Act, I wish it had been whether you can do all these 3 things at the same time, or actually you have to stage them, whether it was pragmatic or necessary to try to make all of these improvements simultaneously. But indeed, in the legislation, it does, because changes in healthcare delivery and changes in cost have the greatest political challenges. That's the section of the Act that is the most tentative. I wish it were much more bold about payment reform. I wish it were much more bold about constraining the non-taxability of employer-provided health insurance. But at the end of the day, I actually think it's a reasonable start, and I think it is political tragedy that the few things that were not fully funded in the Act when enacted are now being challenged by the Republicans in the House of Representatives, and those things tend to be the only things, like the Independent Payment Advisory Board, that might actually improve the delivery system and reduce cost.
All right. Do you folks wish to comment?
I think Josh has a lot of experience with attempts at rate control in Massachusetts. Maybe you want to talk about that?
So if we believe that the Massachusetts law was the inspiration for the Affordable Care Act, and I am in the camp that it actually was not that much of an inspiration, they share some common elements, but that's about it, then we can say no, they didn't. Now, if you talk to folks that were involved in DC, they'll say accountable care organizations and payment reform was what, and IPAB were the cost control mechanisms. We didn't have those in Massachusetts, but they just went back and passed a massive bill in July of this past year to try to get at cost control in our state. And we have a history of rate setting that they got rid of, and now we're headed back in that direction in Massachusetts. And so I think we agree that there's not enough of cost containment, but I'm not sure that we would agree on what that cost containment should look like. In fact, I think it made it worse. It made HSAs look less attractive for people, and I think that's a move in the wrong direction.
Dr. Sage had earlier praised Friedrich Hayek and said that we should all do more to listen to Hayek. Well, one of Hayek's central insights was that central planning is really difficult because it's very hard to get accurate information from the hinterlands with which to centrally plan everything. And this is the disadvantage, and this is why attempts at reining in the costs of Medicare have been mixed at best and ineffective at worst, because it is very difficult. If it requires an act of Congress or even this Independent Payment Advisory Board, which will say, well, we got to do this or we got to do that, and the IPAB's powers are actually quite limited. All they can do basically is pay Medicare Advantage plans less money, pay drug companies a little less money, and pay providers less money. That's not really reform. Reform would involve reforming the insurance, the insurance package, the benefit design of Medicare. So these centrally planned approaches to rate control have historically not worked, and they haven't worked well. And again, if you don't agree or your intuition is in a different way, just look at the spaghetti chart I put up, which shows countries that do take a more aggressive route towards regulating prices have not successfully changed the trajectory of growth in national health expenditures.
So I could comment on the disagreement here, but let me instead just comment on the agreement, because this piece about Hayek is actually worth your attention. So Hayek wrote The Use of Knowledge in Society in 1945 and published in the American Economic Review, and it's about why free markets like the West are better than central planning like the Soviet Union coming out of World War II. And the point he makes is that the reason central planning fails is because it doesn't have access to information that free markets have because they have accurate prices. So when you think about healthcare today, realize that you're not getting an informational advantage to have individuals pay unreal prices. Now, it might be, if you were setting up a system from scratch, that if you allowed health savings accounts and real market pricings to emerge from the beginning, you'd end up with a better system. I suspect you would. But that doesn't mean that we can take the current system and the unreal prices we have, ask people to evaluate and pay them, and within any reasonable time frame end up with something that looks in a Hayekian sense better than central planning.
Thank you. And now, from the floor, an inflammatory question for Mr. Archambault. Do you believe that people who make poor lifestyle choices should be required to pay higher premiums?
That's a great question, and we're actually seeing it play out in, at some private companies. CVS was the latest one that made headlines for what they were requiring. I think this question partially depends on the activity. I do think that, for instance, for smokers, we know conclusively how bad it is for you. And I think if you ask most smokers, they would know too. So I think that there is a legitimate question along those lines to say, for those behaviors that we know are going to cost more, we can talk about this. But let me just focus and go back to something I said in my remarks. We know that 70% of medical costs now are treating diseases that are the result of lifestyle choices. And I would much prefer, instead of being at the end of that, saying, how are we going to penalize somebody and give them higher premiums, and saying, how can we actually incentivize them or engage them at the beginning? And we hear a lot about that 20% of patients account for 80% of the care. The problem is those patients don't all stay at the top. They often drop out of that high-cost category. And so how do you engage them on a year-to-year basis to stay healthy and be healthy? And I think that giving them the tools through an HSA-type plan is a much better way than having this long, drawn-out conversation, and quite frankly, having me or somebody else saying that behavior is appropriate or not, we're going to penalize you or not. I'd much rather engage them instead.
So the answer is?
Engagement, encouragement instead of penalty.
Okay, all right. So I'm going to take that to be a no.
You mind, Dr. Hughes, if I just add one comment? Sure. Yeah, and Dr. Sage brought this up in his remarks, which is that one of the economic attractions of health savings accounts is they eliminate this moral hazard, right? Because if you're saving for your own health care, then those costs accrue to you when you make unhealthy choices. And that's, I think, one of the reasons why the Singaporean system is so successful. They used to have an NHS-style system, like a British-style system. They changed remarkably a couple decades back into this HSA-type approach. And it does encourage people to make healthier choices because they pay for it. They pay more. You don't have to raise their premiums. They pay more because their health savings accounts get depleted more. So if you're in control of those dollars, you have a lot more economic incentive to engage in healthier practices.
So you're eliding the whole notion of premiums altogether.
Well, yeah, in a sense, yeah. I mean, like if you have a health savings account with a catastrophic plan, if you get hit by a bus or you have a stroke or you get cancer, you're covered by the catastrophic insurance component, which is what insurance is really meant to be to begin with. It's meant to be for catastrophic loss. And for relatively routine expenditures or chronic expenditures, you use your health savings account.
So I'm actually not going to put them harshly on the spot over this question, except to point out that there are two kinds of moral hazard at play here, and you're now hearing that health savings accounts discourage both. There's the moral hazard that you usually associate with something like a homeowner's insurance policy, where if you think you're going to be robbed, you would normally lock your door. If you think you're insured, maybe you don't. And sort of what risk do you subject yourself to? That's never been the major moral hazard in healthcare. The major moral hazard in healthcare is if you get sick, what do you draw on to try to feel better? And how much does it cost, and do you care? And health savings accounts were really set up for that type of moral hazard. It's hard empirically and even conceptually to see how they're really supposed to address the behavioral moral hazard either, or I should say at the same time. But the broader point that I think is worth making here, connecting to health behaviors and healthcare costs, is, look, this is really serious. And this is why when you at least structurally examine the ACA, you say, okay, it's good that it dealt with insurance and healthcare and underlying health, because this is the underlying health piece. And you might think that future generations of Americans, or even current generations of Americans, are going to have shorter lifespans and be sicker than their predecessors because of obesity, because of other types of multiple chronic disease. You'd be wrong about that. They're indeed going to be sicker than prior generations, but they're actually going to live longer. And that's even worse. So at least in terms of the challenge, it's worse both for the challenges of affording the system and, frankly, for the disease burden on the people. I mean, there are going to be a lot of people in the next generational cohorts who are less productive, less well-off, and unnecessarily so. So it's not just that you're going to have short-lived sick people, you're going to have very long-lived sick people.
All right, here's another question for the opposed group. Healthcare spending in the United States in part reflects the fact that the U.S. subsidizes innovation from which the rest of the world benefits. Innovative drug companies plan for a more lucrative U.S. market and develop therapies accordingly. The fact that other countries free ride on this innovation and resultingly appear to have, quote, lower healthcare costs, that's the result, should not be held against the market-based feature of the U.S. healthcare system, which actually allows other countries to benefit from this innovation more inexpensively. Do you want to repeat that because it asks you to agree or not?
I'm okay. Pharmaceutical costs are not the big ticket items in American healthcare spending. You know, it's roughly 10% of healthcare spending. Hospitals are the largest sector, and overall the physicians are only maybe 15% because physicians have these magic ballpoint pens that allow them to write orders and prescriptions and referrals and the like. Physicians are actually responsible for 70% or so of healthcare spending. So you're all very powerful people if you didn't realize that. You know, yes, we do, as the United States, subsidize a huge amount of pharmaceutical and device innovation. Now, it's pharmaceutical and device innovation. It's not innovation in a lot of other things that would be equally beneficial both for ourselves and for other countries. But I don't think that the payoff from that innovation either makes our costs that much higher or makes their costs seem that much lower.
Okay. For those in favor of the proposal, the for-profit insurance spends 20% of money on administrative costs versus Medicare 5%. How do we think they are able to reduce costs? That would be Medicare.
All right, I don't want to bore everyone with a lot of numbers, but I'll do my best. And if you want a detailed discussion of this topic, Google my name and the myth of Medicare's low administrative costs, in which I discuss this in a great amount of detail. So it's true that that administrative costs with health insurance in the U.S. are probably higher than they should be, and more competitive systems of insurance, like they have in Switzerland, like they have in Singapore, do a lot to address that. And the premium support system that Paul Ryan supports, the ACA exchange, et cetera, those kinds of systems do address some of these issues of administrative costs in an organic way. But the important thing to understand is when we compare private insurers to Medicare, it's not an apples-to-apples comparison for a number of different reasons. The first is that Medicare is a government program, so it gets to outsource a lot of its business practices to other government agencies. When you pay premiums to Medicare, they're collected by the IRS. An insurer has to collect them himself. That's just one of many, many examples. But the biggest difference is that Medicare is for people, generally speaking, who are older than 65. Older people tend to be sicker. They tend to consume a lot more health care. Private insurance is generally for people under 65, who are younger and therefore healthier. What administrative costs measure is the amount that you collect in premiums relative to the amount you spend on health care and health claims. And that difference, whatever's left over, is called administrative costs, or the medical loss ratio in financial parlance. And that's considered the overhead costs of private insurers. Now, the thing to remember is that if you're on Medicare, you're usually consuming this much health care. And so if the administrative costs are here, the denominator is so large that the percentage seems small. But if you're a private insurer and your cost, the amount you're spending on health care is down here and the administrative costs are the same as Medicare, then the administrative cost ratio seems higher because the percentage is higher, right? Because the denominator is much smaller. Now, when you actually compare on an apples-to-apples basis what private insurers pay per beneficiary on administrative costs to what Medicare pays per beneficiary on administrative costs, leaving aside all the accounting stuff that I talked about in the beginning, Medicare actually spends more per beneficiary on administrative costs than private insurers. So the real problem here is one of math and just basic fractions in a way that Medicare's supposed efficiency is misunderstood. One final point I'll make on this, because it's an important topic, because this is really central to a lot of the debates we have in the U.S. on healthcare policy. And that is, we don't think of a bank as more efficient when it doesn't hire security guards. Because if you don't hire security guards, you're more likely to get robbed. But security guards are an administrative cost, right? Some administrative costs actually improve efficiency. So one of the problems with Medicare is that because it doesn't do enough, it doesn't hire enough people to review the claims that come in. As Dr. Rosenthal pointed out, she never gets hassled on her Medicare payments. She sends in something and she sends the paperwork, she gets paid. That's great if you're a physician. It's not great if you're a taxpayer, because a lot of waste and fraud is driven by that process.
And I actually agree with both of those points, though I don't think it's really something that is a strong point of comparison between private health insurance in the United States and Medicare. But I think the explanation and analysis are correct.
Now, we're going to continue asking questions and soliciting responses, but our 30 minutes is up, so I would like for people to begin voting. And I believe we go to, yes. So we would like for you to do your post-debate voting, but in the meantime, let me ask Dr. Rosenthal and Dr. Sage, because much of those in favor of this proposition is based on a system of premium support. In your view, can premium support be made to work, and under what circumstances, or is this something that just has to be dismissed as beyond acceptable? Premium support where people are provided with a set amount in order to purchase health insurance, which actually is a model that the Affordable Care Act, or an aspect of that that's included in the Affordable Care Act. So, your thoughts about premium support, and can it be made to work?
I don't know.
Oh, I can do it.
Well, but I have a very
Sure,
strong
go ahead.
opinion. I don't think that is a good way to go at all. I don't think we should have health insurance. We should have, you know, you pay progressive income taxes and your health care is taken care of, like in Canada. I mean, it's so simple.
You know, now I get to quote Keynes, the quote we all know, which is, you know, in the long run, we're dead. It all depends what your time horizon is. I mean, if you had a 50-year time horizon, eventually health savings accounts might bring down costs. If you have a 50-year time horizon, maybe premium support might bring down costs. But in kind of the realistic term for me, all premium support does is offload some costs of the system that will continue to be paid from the government's books, and is not a good idea.
All right.
I just want to make one comment. I love the phrase that's often used, cost sharing. Isn't that sweet? Don't you want to share the cost of your health care with the government or with your insurance company? I don't.
I don't want to share the cost of my rent either, but, you know, I do it.
Here's a question I'm going to have to reread and make sure I understand it. But, the voting is being tallied, is it? All right. Well, we will plug ahead. Gentlemen, what are your thoughts about premium support? Obviously, you tend to support it. What constraints do you think government needs to impose on a system of premium supports? And let me make sure that I understand correctly that you do in fact support it.
I do. I certainly wouldn't speak for Josh on this. In fact, I would say that, so Doug Holtz-Eakin, the former director of the Congressional Budget Office, and I published an op-ed in Reuters a couple weeks back where we talked about a conservative, a market-oriented path for healthcare reform. That's fairly different than what the standard conservative position is. The standard conservative position is repeal Obamacare, then figure out the rest later. And our view is we shouldn't actually try to repeal Obamacare. That ship sailed when Mitt Romney lost and Republicans lost in the elections of 2012. But that actually the more market-oriented and creditable aspects of the Affordable Care Act can be used as an engine for premium support style reform. And again, the important thing to remember is that the exchanges in the Affordable Care Act are to the right, purely from a policy standpoint, they're to the right of what Paul Ryan proposes for Medicare. Because Paul Ryan's plan for Medicare is a premium support system that includes a public option. The ACA exchanges do not include a public option. The ACA exchanges have a sliding scale of subsidies, very similar to Switzerland, and they cut off at 400% of the federal poverty level. Medicare, even under Paul Ryan, covers everyone. Why should taxpayers be subsidizing health care for Mitt Romney and Warren Buffett and George Soros? We should take that money and redirect it to the poor. So what Doug Holtz-Eakin and I have argued is if we expand the exchanges into the Medicare and Medicaid populations, we can actually provide better care to the Medicaid population than they get today, because Medicaid severely underpays doctors. A lot of doctors have stopped taking Medicaid and increasingly Medicare because they pay doctors so little relative to commercial insurance. So the exchanges are a way to actually increase provider payments for the poor to get better health care, and also subsidize the wealthy less. We subsidize the wealthy too much today. And if you do that, we could actually save a lot of money and give people a lot of choice in their insurance plans, which again is what Americans want. Americans like having that choice. We're good shoppers, or we think we are anyway, and maybe we're dumb shoppers half the time. But in markets, not everyone has to be smart. Only enough people have to be smart that businesses have an incentive to cater to those smart participants, and it works reasonably well. And we can get there from here. I think the Singapore system is a bridge too far, but the Swiss system is relatively straightforward to get to from the system we have today.
The only thing I would add to that is, I think if you move toward a premium support plan, we shouldn't restrict it to a public exchange. There are private exchanges that are out there in which larger companies or even smaller companies are giving their employees a defined contribution, a set amount of money, to go pick the insurance that is a good fit for them. And I think if our goal is truly coverage for poorer people, then we should give them that choice. Let them choose. Is a private exchange going to offer them a better deal with more tools for them? Let them go there. Give them the premium support and let them go there instead of restricting their access just to a public exchange, where in some states they may be functional and others they may not be.
All right.
Can I make a comment?
Absolutely.
I think that patients don't want a choice of plan. They want a choice of their doctor and then hospital. In the private parts of Medicare, the Part D program, the Medicare Advantage program. Well, I'll just talk about the Part D drug program. I work as an advisor to help people navigate that. There's many, many choices of plans, and it's been shown that about 90% of the recipients choose the plan that is not the best one for them as far as getting the most benefit for the least money. And so I think people want their choice of doctor and hospital, but not their choice of plan. And when you have too many plans and you make it too confusing, they simply don't know how to choose. It's very, very complicated. I have people coming all the time, college professors, all kinds of people that just retired and now they're on Medicare, and they try to choose these plans and they're totally perplexed on how to do it. It's ridiculously complicated and confusing.
Now, I'm actually open to the idea of means testing Medicare, and have for as long as I've been doing health policy, which is a pretty long time now. I would caution, we have to think about the underlying health of our population as we go through these aging cohorts, and we really need to do what we can to incentivize people to be healthier and to construct communities that support that, because otherwise we're going to find that if we try to take the younger, presumably healthier elderly currently in the Medicare population and bring them into an exchange-based program, that actually their expenses exceed what the market bears there. And I'm a little concerned about that. But on the whole, I'm open to doing the Medicare population. The Medicaid population, I think it's critically important for us to view completely differently. I think the Medicaid expansion, and this is mainly seen from a place like Texas, that the expansion population, if it happens, would be huge, rather than a place like New York that already has most of these individuals in Medicaid. But the Medicaid expansion is a great opportunity to construct a healthcare delivery system that actually works and that we can actually afford. And so I'm very nervous about taking Medicaid and moving it into the private insurance realm, thinking we've done something there. What I'd like to do is not worry about the insurance coverage from Medicaid, but worry about the way that healthcare gets delivered to those beneficiaries.
All right, thank you very much. I believe we have results. Not yet. Okay, so we can carry on. Actually, okay, so what did I do with my next question? All right, there seems to be some disconnect between elective, emergent, and preventive services. Mr. Archambault mentioned that the free market brought down prices for LASIK, which is elective. Can he, that would be you, comment on the benefits of the free market for emergent and preventive services? This seems unfeasible without government.
I do think it's important to realize that when you get hit by a bus, we are not expecting you to call the emergency rooms and figure out which one's going to give you a better deal. That's why you have catastrophic coverage that goes with an HSA type plan. So I think the point of an HSA is when you're getting your knee replaced, if you're getting surgery, you're now going to have an incentive. You have an opportunity to go around. I mean, I'll just give you one example. In Boston, you have one hospital system in which if you're getting a knee replaced will cost you $18,000. Less than a mile away, $7,000. Same quality if you look at the quality metrics, often the same doctors coming from the same schools, maybe even did their residency at the same place. That's what I'm talking about. And I think the amount of savings that you can garner there to have those institutions become much more responsive on price gives you the latitude to then be able to cover those things that come up, whether you get hit by a bus or you have, you get cancer or something along those lines. So I think it's really important that we're not advocating that you just open it wide up and for everything you have to shop, because we realize that we're not quite where we need to be on transparency and price. So there's a way to go there, but you have to start getting people involved on that and looking for those sorts of things to be able to save that kind of money.
I think it's an absolutely terrific question and something I talk about and write about a lot, which is that healthcare is not one big blob. There are different kinds of healthcare, and in just the breakdown that the questioner asked. Because that's often a straw man that's used to say, well, markets can't work. What if you get hit by a bus? And of course, we agree. You know, that's where the Ken Arrow thesis is more plausible, where you do get hit by a bus, you're unconscious, so obviously you can't shop for care when you're unconscious. That's where insurance comes in, and insurers, by claims management and price negotiation, can negotiate among different providers how you're going to get covered, and then the competition is among the premiums for that catastrophic coverage. But for things that you can do when you are conscious, you should be able to shop for care. You should be able to shop to see where you can get your knee replacement or your baby delivered or your intervention or cardiology, your cardiac stent gets put in, right? Your coronary stent gets put in. These are the kinds of things where you can shop. So that's what we're advocating. If you look at the statistics of national health expenditures in total in the United States, about a little under 30% is acute care, emergent care. The rest is chronic or routine. And so if we can take that 70%, which it bears mentioning is over $2 trillion, and do a lot with that, we'll get pretty far in terms of addressing the cost problem.
Mm-hmm. I just had a question that was brilliant, and I forgot it. And you would all be amused by its precision. So, do we have results? You're going to save me from this? No. Let's do the results. If I remember my brilliant question, I will impose it on you momentarily. Jeffrey Lowe is going to provide us with the before and after results.
All right. So before this debate, 14.5% of you supported this proposition. 59.2% of you did not support this proposition, and 26.3% of you were undecided. So our live voting. So after the vote, 18% of you supported this proposition. 73% of you did not support this proposition. And 9% of you were still undecided. So the winner of our debate tonight is Dr. Rosenthal and Dr. Sage. Thank you so much for joining us tonight. If Dr. Hughes has any more questions?
I think we're done.
All right, thank you so much. Thank you for coming tonight.
Thank you.